Those who are coming for the first time, welcome. Those who've been here before, thank you for joining us again. There was a time difference because the US sprang forward. That means we lost an hour, and because of spring, the times and clocks change. So in your time, so for example, in Southern Africa now, it should be 7 o'clock, 7 p.m. So I see Dr. Angela has sent a text. Is that Angela Malto, I think? Nice to have you if it is you. Wow. So let's my corridor became a little noisy. Uh, the format, as always, is I present a case, I show you the H&E, I discuss the morphology with you, and in the chat, you would put in the differential diagnoses. And yes, Sheena, that's why it's an hour earlier. Yeah. Spread the word to your colleagues, those who didn't pick that up, please. The time change does become a bit of an obstacle, particularly in the spring and fall. Um, so, yeah, I would show you a case, give you the history, and then we would you would post your thoughts, differentials, investigations in the chat, and we go from there. Okay. The other reminder is in the chat. I just put in YouTube Diagnexia, and Ava, who's our coordinator, sponsor, and helps us with launching this conference, has put in the link to YouTube. So all of these conferences in the past have all been recorded, and to date, Ava tells me this conference has about um, 10 presentations. So feel free to look at that if you want to, or share with other people, particularly trainees in your area. You can feel free to share that with them. And then the next meeting is April 22, in case we forget, and that will be the time that you are present today. That's when it's going to be in April 22. It doesn't change until November. So we're good for the next 7 or 8 months. Okay, let's kick off then with the first case, and this is a tumor in the thigh of a 48-year-old man. Thigh tumor 48. So here we go. Let me show you a low power. It's a needle core biopsy. There's some fat there which we're not going to go into. I'm just going to look at this solid cellular tumor and take you down and show you the cytomorphology. Firstly, just to point out, you can see that it's forming some of these nests. Okay. Again, the term that people use, organoid, lobular for me would probably be larger, but these are nests of cells, fit in quite nicely. In some areas, they do form a few cords, but predominantly nested. And you can see these nests here as well. And then let's just show you more of this pattern here. Some cells are large and others are pretty uniform. Let's go down on high power just to show you that. Pink cytoplasm, nuclei, some variation in size in nuclei. Okay, and then the cytoplasm's pretty eosinophilic in parts. In other parts, they appear to be a little bubbly. There we go, a little bubbly, and I don't know why that is. Maybe just an artifact. Again, I just show you and speak to what I see, so that it helps you understand the morphology as well, because we are looking at this on a digital slide and microscopy over many thousands of miles. So I like to tell you what we're seeing as well. Again, these round cells, nested, abundant cytoplasm, varying size and shape of nuclei. Okay, let's see what people are thinking. In some parts, they seem to be sort of this loose cohesion as well. And here they appear to be more cohes there. So let's see what people are thinking in the meantime. Epithelioid tumor, that's a good start, Sheena. I like that. Thank you. It is epithelioid. This is in the thigh. Patient is 48 and he's a male. Is there a dermal component, Andy? Uh, I don't know, Andy, and the answer is this was a mass in the thigh, soft tissue mass in the thigh, which the needle core I'm showing you is all I had. So I don't have any dermal parts to it. Uh, Possibly rhabdoid, clear cell sarcoma, epithelioid, Sumera, okay, Miss Sheena there on top. Picoma, alveolar soft part sarcoma, and melanoma. Sumira alveolar soft part sarcoma, and Shamim alveolar rhabdomyosarcoma. All very good thoughts based on the morphology and the architecture as well as the morphology of the cell. So, alveolar soft part sarcoma, just to go through that differential, would be pretty easy to rule in or rule out, because if you have the antibody to TFE3, those are very useful and reliable. Um, if you have fish or in situ hybridization, you could apply that as well for alveolar soft part sarcoma. So those are ways that you can, uh, along with morphology, confirm that. But I think you probably need to have at least TFE3. That would be helpful. And again, I'm addressing you in knowing that not everybody has the luxury of molecular assays and fish analyses. So trying to give you ways in which you would arrive at correct diagnoses. So given that this is a youngish patient and in the thigh, TFE3 would be helpful in that respect. What are the other differentials? I think Sheena had it. The picoma, that's a good one as well. Picoma is good, and then there's also alveolar rhabdomyosarcoma. So again, alveolar rhabdomyosarcoma, you would have Desmond muscle markers. Desmond are useful for that, but specifically you'd want to use skeletal muscle markers, and myogenin, MYF4, and MyoD1 are the useful markers for demonstrating skeletal muscle differentiation. Having said that, uh, the myogenin tends to be more diffuse than MyoD1 because of the primitive nature of the alveolar rhabdomyosarcoma, and myogenin tends to be stronger in the more primitive tumors. Again, having said that, I saw one at Tumor Board today that was equally positive with both MyoD1 and myogenin. So it doesn't always read the textbooks. And the reason I say that is because the classification of rhabdomyosarcomas has expanded over the last few years, and one of those that has been recognized are the spindle cell sclerosing rhabdomyosarcomas. In the early days, the first one that was described, the spindle cell sclerosing rhabdomyosarcoma, was the MyoD1 mutated ones. And those tended to be more MyoD1 positive than myogenin. So it was the converse or reverse to alveolar rhabdomyosarcomas. So just sharing that with you. Be careful in that spindle cell sclerosing rhabdomyosarcoma. They can be very focal, so you may have to do it in more than one blocks. Okay, I don't want to talk too much about rhabdomyosarcoma. Let's go back to our differential. And then there's picoma. Sheena's mentioned picoma. I see Olga's got mesothelioma. Unless you're thinking it's metastatic, Olga, knowing that there's an abdominal or chest mesothelioma, that would come into the differential from a morphological point of view. I agree. They look very pink. They look very epithelioid, and some of them did look rhabdoid. And somebody did mention that in the chat, that they do look rhabdoid. Or did I misread that? Either way, the mesothelioma would come into that differential. And again, because it's epithelioid, you just need one marker to confirm or refute mesothelioma. A good keratin is, I like AE1, AE3. It's a cocktail of keratin antibodies, antibodies, and that's useful. So in an epithelioid mesothelioma, you'd like to have a diffuse keratin positivity. Okay, Sumera's just added another one. Let's finish up what Sheena's brought in, the picoma. And picoma, as you know, is myomelanocytic. So you'd want to have muscle markers and melanocytic markers. Again, we've talked about this in the past, but never hurts to repeat it. You can use actin, which is a good myoid marker in that context of picoma. Desmond less so, but is also useful. I like calponin. calponin is good. And then some people also use cathepsin K. And then, of course, the melanocytic markers are HMB45 and melanae. Those are the sort of basic screening tool that you would use for a PCOMA. So those are all good thoughts, and everybody's basing it on the architecture as well as the morphology, cytomorphology. I just want to address here Sumera's epithelioid sarcoma. That's also a very good thought given the morphology, the rhabdoid morphology. The proximal one tends to be more in the groin. This one's in the thigh. And then, of course, the classic conventional ones tend to be more acral in the feet and hands and fingers. So, and again, CD34, keratin, EMA are good screening tools. And if you have INI1, SMARC B1, then that's useful to make that definitive diagnosis of epithelioid sarcoma in which it is lost. Having said that, now I saw a nice one from Johannesburg a couple of weeks ago that was shared with me, and that was in the forearm, in a young woman in the forearm. So it wasn't exactly proximal. When I think of proximal, I think of groin, vulvovagina in women, and peritesticular in men. And in the upper limbs, I think more sort of axilla type distribution. But this one I saw last week was in the lower humerus end of the spectrum, I think. So epithelioid sarcoma would be relevant in this context. And like I say, keratin, EMA, and CD34 helps you. Possibly vascular, yes, they can have these pink cells, and they can look, some of them did look vacuolated. So I can understand why you thought of that as well. But Sheena there has got it right, I think. Oh, there's also clear cell sarcoma. They can look pink as well, and the nested pattern would bring that as well. So Andy, yes, possibly rhabdoid, including epithelioid sarcoma, but also the SMARC A4, B1 and A4. I always do both INI1 and BRG when I'm thinking of SMARC deficient tumors, including epithelioid sarcoma. So I would probably do both in that context. So that for that rhabdoid morphology, and then clear cell sarcoma, again, must rule out. So the way I would approach clear cell sarcoma is generally with an S100 SOX10. That's positive, then go on to the other melanocytic markers. In this case, it was positive for both S100 SOX10 and the melanocytic markers. And when we went into the history, this patient did have a history of melanoma, and in fact, this was metastatic melanoma. So even though I show a lot of soft tissue tumors, bone and soft tissue tumors, remember, always keep melanoma at the back of your mind. In fact, I remember showing this case not too long ago in Johannesburg, and they found some pigment in one corner of the slide and made their diagnosis right off the bat. So I didn't look for it now, but they did find some pigment in it. And again, that may have been a different section. So metastatic melanoma, it is, always keep that at the back of your mind. This would be a nice case to apply what I call a panel of 8. That would be an A1, A3, and EMA. That's for epithelial, S100 SOX10 for melanocytic, clear cell we talked about, and nerve sheath as well. And then CD34 and STAT6 for fibroblastic, and then SMA Desmond. Would be easy to address most of those differential diagnoses you very kindly put on the chat there. That's why, yes, I picked that up, Andy. Yes, I did. I didn't have an answer for you, but I knew you got it on the first look. So that was good. That was good. These are all excellent differential diagnoses, not having a history and working them up quite easily with immunohistochemistry. You can quite safely rule out the differentials. Just what I call that panel of 8 in executing that would get you at least S100 SOX10 in this context, and then it would be the question of, is this clear cell sarcoma or is it metastatic melanoma? And if there's a history, then it's quite easy to rule out. So and of course, if you have access to fish assays, you could do a EWSR1 or FUS, because it's a FET rearranged tumor, clear cell sarcoma. That means EWSR1 FUS may interchange as that fusion partner. Okay, any questions? Just got time to go and check if there's any questions. Okay, Andy's point there. All right, no questions. Let's move on to the next case that I have for you. Let's see, what do I have here? Just moving on. I think this is more now moving to sinonasal, 24426. If I can find it, where is it? There's it here, right at the bottom. So this was a sinonasal mass, and adult male. I don't have an age for you, but sinonasal mass, and this is what was biopsied or curated from the sinonasal mass. Low power, just to see they all look the same except for this bloody and hemorrhagic and possibly, I think, fibrinoid necrosis. It's more fibrinoid necrosis. Okay, let's look at the tumor itself, and I think that first, any field will do, but let me just show you on this field, just a higher power. Okay, I'm not even describing this for you. I'm just going to let you speak to this. There's some nice morphology here as well. So remember, it's sinonasal, adult male. There should be some quick interaction here. Any thoughts? How's the stroma? Not much stroma here, Sheena. I mean, this was clearly an exophytic process here, and the surgeon was able to scrape out some of this. But if you're asking what the radiology is, then it was a destructive mass. If that helps you as well. Sinonasal only. That's a very good, Jan. That's a very good point. Tom, okay, Tom. Looks intestinal and dysplastic, sinonasal only, intestinal type sinonasal. Yeah, that's absolutely spot on, Jan. And the question that Jan posed there, I mean, this is not a diagnostic problem. I'm sure you all see a lot of intestinal carcinomas every day, and you can see the goblet cells in here as well. And clearly, this is not the low-grade sinonasal adenocarcinoma, but would be the high-grade definitionally because of the intestinal differentiation, right? You can see the goblet cells here. There we go. So clearly a high-grade sinonasal adenocarcinoma. But the point that Jan brings, just going back to the screen that has the chat, the point that Jan brings to the table is you have to rule out a primary intestinal adenocarcinoma, colonic adenocarcinoma. That has to be mandatory. So clinical and radiological are important in that respect. I would not sign this out as a primary sinonasal, and I would always ask the question or place the question that a metastatic adenocarcinoma has to be ruled out from the GI tract. So just briefly, you know that the adenocarcinomas in the sinonasal tract, has some sort of diagnostic approach, and you always want to rule out the salivary gland types. For example, adenoid cystic carcinoma, and then there are a few unique carcinomas that you should think about in that context, which I won't go into, but HPV multiphenotypic type carcinoma would be another one. But morphologically, those are quite distinctive and different from this. So salivary gland to rule out first, and then with this glandular component, is it high grade or low grade? The low grades tend to be genuinely low grade. They're usually papillary, and those are the ones that occur in woodworkers. Yeah, that's a question, Sheena. Was your patient at woodworking? To my knowledge, that you can check me out, Sheena, please. the low grade ones are the ones that tend to occur in the woodworking industry. But you can check that out and punch it into the chat, please. But yeah, not a diagnostic problem, but just something to share with. These are exceptionally rare, but they do occur. And when you do see one, then always rule out a metastatic from the GI tract. Okay, I think the next one, we're staying with the head and neck, 21056. There we go, 21056. So this is a node in the neck. I don't have the level for you. I don't know which level of the lymph node it is. All I know that it was a neck lymph node that was removed. And you can see that there's no or not any nodal tissue, but I accepted it as a lymph node. I'm just looking to see if I have some residual lymph node. I do not, but I think accept it as a lymph node for your differential diagnosis purposes. And let's look at the tumor itself, which, as you can see, is completely replaced the lymph node. These are all just crush artifact. I don't think they're lymphoid tissue. I think they just crush artifact. Let me take you to a nice field that can give you both architecture as well as, there we go, architecture as well as cytomorphology. That would be something to consider there. You can see the architecture. And then the cytomorphology, just closer to it, fairly uniform looking cells. Just a little higher power, just to take you through that. Okay, so this is a lymph node. This is extremely difficult. This you have to think outside the box. Really have to think outside the box. And when I first saw this, I was quite surprised. But it was removed by the surgeon, and we checked the clinical history, and yes, it did fit. But it's let me just say, it's clearly metastatic for your purposes of deliberation. It is metastatic, and this is a node in the neck. And I'm curious to see what the panel is thinking here. Okay, so Sheena, neuroendocrine right off the bat. Angela, the medullary thyroid. Seminoma from mediastinum. That's a very good thought, that, Jan. Seminoma, you sometimes can pitch up in the head and neck. I've seen that. They even can come from the testes. I've seen that, creep all the way to the neck from the testes. Seminoma, neuroendocrine, MTC, medullary thyroid carcinoma. Rouhani, neuroblastoma. Ooh, okay. Nut midline, and then germ cell. So these are all very good, very, very good differential. You've got it. The answer is in this panel. But as we have to do is just discuss the different options. So it seems like neuroendocrine markers have to be done, germ cell markers have to be done, and then of course rule out carcinoma, lymphoma, melanoma. That panel of 8 I talked about very nicely rules out carcinoma and melanoma. And then lymphoma, I don't have that as a panel, but when you're thinking lymphoid, then a basic panel like LCA, CD45, CD3, CD20, I think are useful. Some people may like to include a nuclear marker as well, which is fine. You can do that like PAX5, so that would be helpful as well. The neuroblastoma comes into the neuroendocrine group. The MTC comes in neuroendocrine. Nut midline, I'm afraid you need to have an antibody for that. So the fusion with the nut, that's nuclear protein of the testis, that's probably the only way you're going to make that diagnosis. So you have to have that antibody, and think about it. And they're not necessarily midline, even though they were first pitched to be midline head and neck. They've occurred in other sites as well. And the morphologies can be quite vast. There was a nice paper in histopathology, either 24 or 25, with a heterogeneous morphology. I'd suggest looking at that paper, histopathology, nut midline, nut carcinomas, morphology. That paper will come up, and you'll see 4 or 5 different morphologies. Initially, they pitched it as being round blue with abrupt squamous differentiation, but that paper goes into other morphologies like even adenocarcinoma as well, or glandular differentiation as well. So worth looking at that clear cell differentiation and in even large anaplastic looking areas. So go through that because nut is highly aggressive and you should have that antibody. Germ cell, well, easy again. Germ cell, I hope you have SEL4, OCT3-4, and the yolk sac markers, and of course embryonal CD30, so that can be ruled out. Same seminoma as well. Breast lobular, this is a man, okay? I didn't tell you that. He's 65-year-old man. Let's go back to the neuroendocrine markers. And neuroendocrine, when you mention neuroendocrine, and when I'm thinking head and neck, then three types of neuroendocrine tumors come to mind. One is the neuroendocrine, we're talking more malignant rather than the neuroendocrine tumors that you know in the GI pancreatic sector. We're just talking malignancies here, okay? So the neuroendocrine carcinomas, small and large, morphology is important for that. Dot-like keratin as well. But then again, I apply synaptophysin, chromogranin, as well as INSM1, which we have. It's a nuclear marker. And if I'm thinking neuroendocrine carcinoma, I always do a Ki67 because in metastatic sites, you can get caught out between small cells and the neuroendocrine tumors, which are very low Ki67. So always throw that in as well. So MTC, yes, you can do the calcitonin marker. CA is also, monoclonal CA is also a good marker for that, and then thyroglobulin, TTF as well. And then neuroblastoma, Ruani, yes, good query. This is metastatic neuroblastoma, metastatic olfactory neuroblastoma. So it would be positive for all of those markers. And then, of course, you'd be able to demonstrate the sustentacular cells as well with S100. They not always present. Sometimes have to look for them, and they can be difficult to find. The reason I put this into the seminar set is, one does not necessarily think about metastatic neuroblastoma in the context, but head and neck, and like I said, thinking outside the box is helpful because most of you are, I'm sure, general surgical pathologists, and you'd be thinking about that. So your range of differential diagnoses are most welcome in that context, and helps me think and puts me on my toes to think about these things as well. So metastatic neuroblastoma, just to complete that conversation, because the new thing on the block is not really new. I think it's about more 5-6 years old now. Is the so-called olfactory olfactory carcinoma. So those are also neuroendocrine positive, and they can also have morphology and architecture that resembles olfactory neuroblastoma. But the olfactory carcinoma is diffusely keratin positive, and those are described by. There was a nice paper by Lisa Rupa as the first author, but Justin Bishop is also on that as well. And that's the first paper. I think I'm going back quite a number of years. You'll have to go AJSP, Lisa Rupa, Justin Bishop, olfactory carcinoma, and that'll come up. And we've picked up a few of those. So, in thinking about olfactory neuroblastoma, think of olfactory carcinoma as well. And those they're aggressive. So picking them up is going to be a treatment management issue as well. Let's see. I'm back to question. Any other questions? I don't see any other questions in the. Let's go back to what else have I got for you. For that, I've got to go back to the screen and look at my. All right. Let's do a straightforward one before we move any further. There, this one here. Andy was asking about skin. Here we go, skin, Andy. Foot, 75, male foot. So we have 3 sections of skin. You can see the epidermis here quite nicely. And there's a tumor sort of mid-dermis, extending to deep dermis as well. And this is artifactual. These holes are artifact. So forgive me. I usually get a recut for the seminar, and I just take what I get. I don't have the luxury of choosing better slides, so this is all artifact here. But you can see this tumor, fairly cellular. And again, I try not to give you too much of information, but I will show you on higher power what this. These are lymphocytes, just to give you a comparison, and these are the tumors. That's an artifact there. Let me see. Let me see. I'm looking at the chat. Any differentials? Okay. People want more morphology. All right. Perhaps on this side it's just a little more cellular here. Yeah, this one. Yeah, this was more cellular. Blister cells present. Oh dear Angela, I haven't thought about blister cells. Uh, Blister cells are those ones that they use for hemangioendothelioma, I think, right? Yeah. I like to call it vacuolated. Blister cells are present. Rouhani vascular neoplasm. Gonzalo Kaposis, Angela vascular, Tom KS, Sumera vascular. This is just a classic Kaposi sarcoma. Let's just go look at it. You can see these beautiful spindle cells across there. These are cut across. And if you look on high power, there's some hemosiderin here as well. Uh, these vacuoles are obviously attempts to form lumina. And then there's, of course, not too much slit spaces, but I guess you can imagine some of them there as well. More hemosiderin. And then those of you who like that eosinophilic globules, there you can see those in the cytoplasm as well. More iron as well. And I saw a few plasma cells as I looked around the slide. I'm trying to find some for you, but that's sort of the hallmark of morphologies that we use and still use today. Yeah, this is Kaposi sarcoma, and I always do an HHV8 here in my present department, but I know some of you, are happy to just call it on morphology. There's these eosinophilic globules, and I have no problem with that. And okay, any questions on that or comments? Let's see, Tom. Yeah. That's probably referring to a paper. Yes. Thank you, Tom. That's by Wayne Grayson, a good friend of mine in Johannesburg, who wrote this paper a few years ago now. But what he does in that paper, and not many people think about this, is the varied morphologies of Kaposi sarcoma. There's about 10 or 12 different morphologies: lymphocytic type and hemangioma type, etc. So be aware of the different types, and you may not necessarily think about it in your practice. There was also a recent paper in I think it was American Journal of FRCPath, looking at morphologies in the GI tract as well. Some of them can look sort of lymphangiomatosis, some can look hemangiomatosis, and some can even look like inflammatory polyps. So I think, look at those pictures and be cognizant of those different morphologies that Kaposis can present in, and in the setting of immunosuppression, which here nowadays see more sort of immunosuppression in patients with transplants and rather than HIV. We know angiomatoid fibrous histiocytoma. That's as a differential. Oh, let's see. So the different types we talked about, the GI tract we talked about. So look at those papers and pull them out and look at it. Vinod asked the question. AFH generally, can be deep dermis and subcutaneous. also very well circumscribed, but classically has this lymphoid cuff around it in its classic picture. They don't always have that, but they do have a very typical lymphoid cuff. Uh, the point that Vinod is making is, could these be histiocytoid? Remember, the cells in angiomatoid FH have not yet been worked out, but they can be Desmond positive, very focal Desmond positive, and they can look sort of histiocytoid. So it's a combination of seeing those cells, thinking about it with that lymphoid cuff, and if you have fish for the appropriate genes, you can apply it. Again, FET, EWSR1, FUS are useful, and then the Krebs is the fusion part and the family of Krebs, which we've talked about in the past as well. And that's a way to confirm that. But I think on morphology, if you have a good lymphoid cuff in a young adult, uh, superficial, you can make that diagnosis. Uh, this has, again, I was born in Africa, so I saw capuchins, and in my training and as a young attending, um, with these sort of eosinophilic globules, the slit-like spaces. I guess it's reasonable, I guess it's reasonable to put it in the differential, but once you do your vascular markers, remember KS is positive for CD31 and ERG and CD34. They're positive for CD34, so those are useful markers, which are negative in AFH, angiomatoid FH. This is a more practical question, Andy. But would you still run your panel of 8 for a case like this way? No, Andy, I would not. Again, I'm not being a morphological snob. But yeah, Gonzalo, I agree with you. Just maybe HHV8 only. Like I was saying, I spent since 2016 all the way to 2024 in Botswana, minus the 2 years of COVID. I used to sign out cases, and Angela would know this, and so the other attendings, young attendings, know. We would sign this out on H&E. We'd sign this out on H&E. Although I should add that the setting of HIV was known as well. I guess here, like I said, the setting or backdrop of immunosuppression here in my own practice here is not exactly HIV. It's more the immunosuppression from iatrogenic causes, and I use the transplant as an example of that, and doing the HHV8 in that context. So I leave that to you primarily. I mean, it's dependent whether you have HHV8 in the first place, and then go from there. If you don't, and then you wanted to confirm vascular differentiation, then you could do that, and finding all of those fine morphological features are useful. That's how I did it in the 80s and 90s, and signed them out on morphology. So yeah, it's a good question, Andy. And I remember a good friend attending of mine who brought me a case, and this was, I forget the location of it, but it was histiocytic and had the nice irregular nuclear membranes as well as grooves, and they were positive for CD68 and S100, and even had a few eosinophils in it. And I forget the setting. It was a young adult, and I don't know if it was lung or thereabouts, but in the context of morphology, S100, CD1A, you're happy to call it an LCH, Langerhans cell histiocytosis, but Langerhans was negative, and the question was, would you sign this out as an LCH? This is exactly what Andy's question brings to mind as well, is when and how do you use these? And I said to my colleague Flynn, I said, yes, I would sign this as LCH, no problem. This is how I did it all of my training years and my earlier years. Now we have Langerhans, and you always want to have that marker inclusive as well. So it does bring that story to mind, which I'm sharing with you. It's more sort of, it's a little more than philosophical. It's practical, like you said, and it is practical. Let's see, Rouhani has a comment. The patient has multiple lesion persons. Is it considered a met or a wild? That's a good question. And, I'm not aware that KS metastasizes, Rouhani. I think it's more sort of widespread. I think it's more widespread because these are locally aggressive. And if you cut them out, they're good to go, really. Uh, but I don't know the more modern therapies that are used. But my sort of, again, fact check me, check it out. Uh, my knowledge of these is it's more the widespread multifocal rather than metastatic. So unless that's changed, maybe we can ask Wayne Grayson, who's an expert dermatopathologist in Johannesburg and probably sees a lot more than all of us put together of KS. But that's a good question. My sense is that they're all widespread virus with local lesions. All right, because it's considered to be an intermediate biological potential, locally aggressive. I don't think it metastasizes. That's my sense. Okay, but I stand to be corrected. Remember, we're on YouTube now, so go and fact check me. Okay, all right. Any other questions? Sorry, those are all good questions, guys. Yeah, that that does stimulate the conversation, and I do appreciate that interactive process there. Um, Angela, you are Angela Mount. I just have to say yes because I referred to Botswana a few times, and I'm hoping that that is you. All right. Uh, let's see. Let's move on then to just another straightforward, simple one. 21359. Uh, this is a this was a parotid gland mass, uh, and you can see these large sort of cystic areas with this pink material. I'm just going to show you the adjacent parotid gland. Not much of it, so you have to accept. You have to believe me that this is parotid gland. Oh, there's some here. There we go. There we go. There's some peripheral parotid gland here as well. I'm not sure if this was FNA'd, but immediately here you can see these cystic spaces. And I know all you cytopathologists there would love this on an FNA. But you can see these cystic spaces. You can see what they line by. There I say it looks bilayered, right? There's a lower layer and an upper layer, cuboidal columnar. And then let's take another area here as well. Okay, fairly innocuous looking. Let's see what the thoughts are immediately. I love to see what thoughts are. Sumera Wharton's. Okay, the lymphoid tissue is missing, Sumera. That's what's missing. That is Angela Maoto. Okay, yes. Sumera Wharton's, the lymphoid tissue is missing. More sort of oncocytic looking. Correct. It's more oncocytic looking. Let's go to the this area here. And like I was saying, you cytopathologists would love to see this on cytopathology. Okay. So the lining is very bland looking, and like was said, oncocytic. Yeah, there we go. Oncocytic, very bland looking, bilayered. I just want a name, and I showed you that. Yes, more oncocytic. Maybe well-differentiated mucoid just has one cell. There's just bilayering. Bilayering, I think, is a very useful feature to rule out mucoepidermoid carcinoma because you don't get that in mucoepidermoid. You see it in Wharton's. It was a nice paper by Raja Sitala and 3, 4, maybe more, 4, 5 years ago. I lose track of time. Which said that when you see this bilayering, even if it's very focal, it's very useful to rule out mucoepidermoid carcinoma. Now we're talking about the oncocytic variant, right? And it's very useful to rule that out. So this does have a very nice bilayering, and based on that that paper by Dr. Sitala is in Pittsburgh by the UPMC, and that would rule that out. So bilayering, I think, is a comfortable feature to rule that out as well. Let's see, bilayering more clearly. Yes, benign. That's why I like to mention the morphology, because I understand You're 8,000 miles away. It's very difficult to see this on the screen. Ruani, benign. Yes, I agree. It's benign. So the name. Let's see. Tom. Oncocytic cystadenoma with abundant ispasated amylase crystalloid. Spot on. And that's exactly. I did not make that diagnosis. I showed this to my colleague, Dr. Belosh, and he was the one who made that. He's an excellent salivary gland pathologist as well as an excellent endocrine and cytopathologist, and he made that diagnosis. And that's exactly what Thomas put in the chat there. Yeah. They're drooling. I love that. Okay, cytopathologist will be drooling. All right. Any other chats there? So that's a very good thought. The syringocystadenoma papilliferum. Now you're making me think back to my early training days there, OT. Syringocystadenoma papilliferum. Yes, I guess they can occur in parotid glands. They don't use that term. They're more sort of the the papillary part of it, papilliferum. But the syringocystadenoma papilliferum, usually superficial in skin, has those plasma cells and also has a bilayering as well with that papillary structure. I guess this is a first cousin, OT. What can I say? Probably, you can fact check me, but I wouldn't use that here because of the lack of the location as well as the absence of plasma cells. But it does have the papillary configuration and the oncocytic bilayering as well. So, yeah, that does go back many years. And then there's this crystalloid. If you missed it the first time, this is the highest power I have, just to show you this crystalloids. Amylase, Tom called it, amylase crystalloids. All right, let's see what else we have for you. Yeah, let's go for something GI, okay? 22535, there we go, GI. How about this? Needle core biopsies, 56, female, perineal tumor in the perineum, okay? Sort of perirectal, okay? 56, female. Oh, you do get a history as well. Rule out history of renal cell carcinoma. And that is what the clinical came as, rule out metastatic renal cell carcinoma. So all the cores look pretty similar. They all look pretty similar. So I'm just going to jump into one of the cores and see what the team thinks. Okay. Yeah, you can see the cell morphology. I'll just pause that for a minute or two. Some sort of myxoid material. That blue-grain material we've talked about in the past does look myxoid. There was a vessel here. That's why I'm moving to this. Oh, there's a vessel here. The vessel showing that myxoid. I'm just demonstrating that to you guys. You can see the morphology here. You can see the pattern there. Okay, and like I said, a 56 female, history of renal cell carcinoma. Okay, I don't have a size for you, and I do not have a radiology. All I know, it's a perineal tumor in a 56 female, rule out renal cell carcinoma. Now, I'm just going to go to the chat, see what people are thinking. Nothing at all yet. I thought you'd be buzzing with the nice differential diagnosis. Let's show you more of this to expand your thinking. Like I said, they all look pretty similar. There you go. All right. Okay, so we got a smooth muscle tumor kicking in there. Very spindled with myxoid stroma, neural. And so I've got nerve sheath, I've got smooth muscle, and I've got considered gist. Okay, there, Ruhani. Yeah, you got to rule out that myxoid tubular spinal cell carcinoma from the kidney as well. And, PAX8 is useful for that, and epithelial markers are useful for that. Pancytokeratin is negative, and smooth muscle markers is a little tricky because you can get a little action in these tumors as well. LMS leiomyosarcoma, yes, that would have to be ruled out, and of course, you'd want a Desmond to back up if you had a bit of SMA as well. But I'm accepting the differential diagnosis that you've put in there: leiomyosarcoma, mucinous tubular and spindle cell carcinoma of the kidney, gastrointestinal stromal tumor. And what else do we have? Natalie, how would you describe the pattern distribution of stromal cells? So these are spindle cells, and how would I describe these? This would be more sort of fascicular to me. Okay, it's more fascicular. They're sweeping fascicles. Some of them are pretty long, but not as long as a desmoid. I mean, a desmoid would be from this end of the field to that end. So not short either, like a nodular fasciitis, but more like an intermediate fascicular pattern. Just to give you, my own approach to that as well. But the cytomorphology is spindled. Notice that the nuclei are pointed. Okay, those of you who said smooth muscle, looking at the cytoplasm, very pink, yes, but the pointed nuclei is a feature that's sort of not quite smooth muscle. But I would do Desmond as well, and I did Desmond as well. I did actin as well, Cal Desmond. Woman, 56, you have to rule out muscle tumors, smooth muscle tumors. So that is an important point. But note that they are pointed as well. Okay, just to yes, it is a little mixoid, and I think it was Ruani who mentioned the renal cell carcinoma that can look like this, but they tend to have tubules in between as well. It's mucinous and tubular spindle cell sarcoma, carcinoma, beg your pardon, of the kidney. PAX8 is useful for that. And then keratin was negative. And of course, you all mentioned the GIST, and so for GIST, it's CD117 or CKIT, DOG, and then CD34, which is also positive in about 75%. So they were all positive here. This is a gastrointestinal stromal tumor in the perirectal distribution. And again, your differential diagnoses were perfect, as you've all been today. Not too old. How old is 50 something? Not too old, Angela, but too pink. Synovial is much more blue. Myxofibro, you want an alternating pattern of fibrous and myxoid areas with atypia. This doesn't show much atypia. So myxofibrosarcoma, even low grade, much less cellular. This is quite cellular. S100 negative. Remember, you can get a little bit of patchy S100 in GIST, so you have to do your panel always. Tom, grade differentials already. Fibrosarcomatous, DFSP, SFT. Yeah. So again, that sort of panel of 8 I mentioned earlier would be useful. Adding on GIST and CKIT and DOG are useful for that as well. SFT covered by CD34, DFSP covered by CD34, perineurioma, EMA, you can throw in a GLUT1. Then, of course, the NTRK rearranged tumors. If you have NTRK antibody, that's useful. It can pick up the NTRK 1, 2, and 3. But ultimately, again, there you have to confirm with the FISH for NTRK or sequencing, and to determine the fusions as well. Remember, NTRK emerged, from thinking about the lipofibromatosis like neural tumor that had a bit of CD34 and S100 described by Fletcher in the mid-teens, 2015. That turned out to be an NTRK rearranged tumor. And so seeing these tumors that look like lipofibromatosis or low-grade MPNSTs with stromal fibrosis, perivascular hyalinization, bit of S100, bit of CD34, then you think of that. And if you have access to molecular, either with FISH, NTRK, or next-gen sequencing, you can apply that to these tumors. I use the word tumors deliberately because they can look bland, in which case they may recur, or they can look pretty ugly, or sarcoma, in which case they can metastasize. So you apply whether it's a tumor or a sarcoma based on your morphology. The NTRK gives it a classification, but the grading is based on morphology. So morphology is still important. And what else do we have there? Okay, so this is pretty good, guys. Thank you again for joining me on this hour, looking at cases and discussing them with you. A couple of reminders. The next one is April 22, so it'll be the time that we started today. No time changes here in the US for that. And then, of course, my good friend Professor Chetty reminded me, along with Ava Carr, who's overseeing this conference, that these are now available on YouTube. I'm told that they're available on Diagnexia YouTube, so you can tell your colleagues who've missed. And there's been about 10. Ava tells me there's about 10. So again, thank you very much. See you all on April 22. And tell your friends, more the merrier, because we have a bigger chat.